Good afternoon, everyone, or good morning or evening to some of you. I am Maximiana Rauch from the From Testing to Targeted Treatments program, and would like to welcome you all to this patient engagement open forum session today. In this session, we will be looking at visualizing the patient pathway in precision medicine by co-creating an access barrier cause-effect canvas to identify barriers and best practices across different stakeholder groups. For those of you who are joining for the first time, the Patient Engagement Open Forum is a patient-centered environment in form of a series of events gathering all stakeholders together with the goal of making patient engagement the norm. Given this multi-stakeholder context, these sessions aim to share a holistic perspective of the ecosystem and to co-create solutions that will ultimately advance and strengthen patient engagement work. Next slide, please. Some housekeeping rules. We ask you to be present and engaged during the presentations as well as the group activity at the end. Given the large size of participants, the microphones will stay muted, and we ask you to use the Q&A function for any of your questions, and you may post any comments in the chat. This session is recorded and will be made available to you afterwards. And while our panelists today will provide some unique perspectives and valuable expertise, you as the attendees can also play a role. So let's make this session interesting and insightful together. Next slide, please. So just some technical help. The Q&A button should be in the bottom of the panel for your questions. There's also a chat. You can chat to the panelists separately or to everyone. Once you have asked a question and it's been answered, it will move to the answer tab. So you can always go check what questions have been asked. And you can also upvote ones that have not been answered yet. Next slide, please. So let's dive into today's session. First, we will be hearing from Helena Harnick, who is the Executive Director of the From Testing to Targeted Treatments program, or FT3 for short. She will be giving us an introduction to the program. After, Andrea Ferris, who is the CEO of Longevity, a US-based lung cancer organization, she will be talking us through how Longevity developed their framework for the biomarker testing journey of non-small cell lung carcinoma. She will then hand back over to Helena, who will be explaining the thinking and process behind the access barrier cause-effect canvas. Following that presentation, we will be hearing from Juanita, Tanya, and Carolyn, who will introduce us to the cancer of the unknown primary, which will also serve as an example to test the canvas. Juanita Minar is the co-founder of Missie Tumor Unbekend, a Dutch advocacy and patient organization for patients with cancer of unknown primary. Tanya Knott is the director of the Sarah Jessica Knott Foundation, an Irish-based organization for patients with cancer of the unknown primary. And Carolyn Love, who is a research scientist at the Netherlands Comprehensive Cancer Center, as well as the co-founder of the Dutch Cancer of Unknown Primary platform. And last but not least, we will be needing your input and feedback for the canvas in a group activity, which I will explain a bit later. So over to you, Helena.
Hi, thanks, Maxi, and welcome everyone. My name is Helena Harnick, and I'm the Executive Director of the From Testing to Targeted Treatments program, which we call FT3 for short. FT3 is a global multi-stakeholder collaborative program to make precision medicine a reality for all patients who could benefit from it. The FT3 members and community believe that a true multi-stakeholder program, one that involves diverse stakeholders through shared decision-making, is the best way to address this very complex issue. FT3 is starting with focusing on cancer and testing. It is working on the principle of openness, and the members believe the importance of developing practical solutions to make precision medicine a reality on the ground. We aim to accelerate existing efforts in precision medicine and to help scale best practices. There are three main pillars of activity. The first one is to support data and evidence development, to be able to better understand the benefits of precision medicine on patient outcomes and to build the value case. The second key pillar is all about how we can support decision-making between patients and healthcare professionals through better education and awareness. And the third is all about building the accessibility conditions for precision medicine to become a reality. Next slide, please. And building on this last point, the reason why the FT3 members felt that it was important to focus on the accessibility conditions is because precision medicine is a very complex topic and also a very fragmented landscape. It is complex not only in terms of the rapid speed of change, but is fragmented also in the big varied nature of the different types of organizations and actors that are involved in this topic. There's fragmentation in terms of ideas, in terms of focus area as well. We often find that there are some organizations that are looking at this more from a policy or advocacy point of view, others who focus more on education or maybe on research. There's also fragmentation in terms of disease condition and also in terms of geographic focus. Depending on which country you're from or the geographic focus of your area of work, the precision landscape can be really different. And in FT3, the members believe that for the patient to benefit, we really need to take this whole health system view to see how we can connect these bubbles together and to also consider all the different kinds of challenges that might exist across the whole health system. Next slide, please. So this is where FT3 comes in. Our unique approach is to act as a global catalyst or accelerator. And what we are trying to do is to identify translatable good practices and learnings. And how does that really work? Well, in the first instance, what we have been doing is identifying common needs and opportunities. Then what we have been doing is conducting mappings to identify good learnings and best practices and seeing what we can do to build on them and to make them replicable. If we identify a need where a good practice does not exist, what we are doing is to co-create new solutions, but always drawing on existing knowledge. And most importantly, what we are doing is trying to create a positive momentum and to see how we can use the FT3 community of practice to collaborate with us to build on these solutions and to test and share the outcomes. Ultimately, what we are aiming to do is to create a suite of practical resources and support to be able to accelerate precision medicine. In the near term, we are doing this for champions of precision medicine, including patient organizations and key stakeholders, including key healthcare professionals. And our aim is to develop resources and support that are adaptable to different contexts, including different disease contexts and geographic contexts. So the first step is to identify common needs and opportunities. And in fact, the last patient engagement open forum in September 2020, you helped us with this. So in this session, if you were there, you might recall that you helped us identify different kinds of patient support and information needs. And you can see a summary on the screen of the ones that were most frequently mentioned and also the ones that were ranked the highest priority. So in terms of numbers of frequently mentioned needs, we saw that the most important topic was all about access, including financial access. There were also some needs around learning about and how to join clinical trials, and also a lot of questions about testing, including understanding biomarkers and understanding biopsies and tests. We also asked the participants to rank the needs that were identified by priority. And the ones that were ranked the highest included where to find reliable information, when to have a biomarker testing, and also how to know if a treatment is best on the best available evidence. This information has been really helpful to give us a foundational knowledge of where we can make our mark. In the awareness and education pillar, it has also helped us inform the creation of adaptable resources, educational resources for patient organizations. And the first activity that we have been working on is a Q&A resource builder that will be shared shortly with the precision medicine community. We also have a link there if you're interested in learning more about what we did in the patient engagement open forum last year, and we can also paste that in the chat. Next slide, please. So we had a really good insight from the last patient engagement open forum, but something that we were also discovering, the FT3 team, but also the FT3 community as well, is that it's not enough just to look at education awareness. And we were learning that it's also really important to think about what is the patient experience and to understand that really well. And also we were learning that it's also really important to understand what are the operational access barriers that might exist. In fact, beyond education and awareness, we find that there are access barriers that exist at all levels of stakeholders. And in making this understanding, we came across some really interesting resources, and a longevity example from Andrea is one of them, which she will present shortly. And in this discussion today, the idea is to discover how we took this best practice and turned it into a canvas, basically a model so that others could benefit from this learning and to be able to apply it on their own. So with that, I will hand over to Andrea.
Thanks, Elena.
Hi, I'm Andrea Ferris. I'm the president and CEO of Longevity Foundation. We are a lung cancer patient advocacy group based in the United States, but we do activities globally. And today I'd like to talk to you about one of the things that we did with respect to precision medicine to understand barriers and opportunities for engagement. Next slide. At Longevity, we define precision medicine as biomarker-driven care, and that can be anywhere along the entire care continuum. And we have programs that address it along the entire way as well. Next slide. And it's our belief that every patient has access to the right test and the right treatment at the right time. And in lung cancer, this is particularly important because it is predominantly being driven by precision medicine and immunotherapy at this point in time as effective treatments. Next slide. So as I discussed earlier, for us, the biomarkers really do play in along the entire continuum. It plays in screening and early detection for risk stratification or understanding what therapies people might benefit from in an adjuvant setting. There are biomarkers as well for understanding recurrence or monitoring recurrence, minimum residual disease after surgery, and then obviously as well biomarkers for diagnosis and to understand what treatments to match a patient to, as well as then again at recurrence or progression to understand mechanisms of resistance. Next slide. So as I said, Longevity, we have a lot of programs along the entire continuum that are all precision medicine or biomarker related, starting from funding research that's biomarker driven, education, a lot of public policy. We do a lot of collaborative efforts with other patient groups and societies as well to uncover areas where there's a common barrier that we can address, similar to our consistent testing terminology working group. And this is an ongoing coalition now where we share learnings across disease and lessons learned. There's a lot of health equity involved with it. We have a lot of studies ongoing how underserved populations are accessing biomarker treatment and care, as well as a lot of policy work. Next slide. So this is the part where Helene asked me to discuss with you. This is a map that we did to help us understand the journey. Not of the patient, but of their tissue, basically, to understand where some of the barriers were. In order to create this map, we did it from a variety of perspectives, as you'll see down the left, from the patient perspective, the provider perspective, what goes on in the lab and with the pathologist, as well as then the payer as well. In order to develop this map, and then on the subsequent slides, you'll see as well the identification of barriers along the way, as well as then possible solutions. It wasn't just something we created off the top of our heads. We actually put a lot of work into this, including hosting multi-stakeholder meetings to understand barriers along the way. We did a comprehensive literature search to understand the journey of the tissue from a variety of perspectives, from the oncologist, the pathologist, pulmonologist who does the biopsies, interventional radiologists. We also did a number of interviews with oncologists and pathologists and patients to understand what their impact was. And then layered onto that the information that we had with respect to coverage or payment and other policy issues. Next slide. So from this, you'll see these are the barriers that were identified. I think that this slide will be available to you afterwards, so I don't know that we need to go into a lot of the detail. It's a bit of an eyesore, but there's issues along the entire journey. Everything from the tissue acquisition in lung cancer up until probably the last 10 years, it was a disease where there were not a lot of treatment options. So oftentimes when a biopsy was done, the clinician would take as little tissue as possible to do as little harm as possible, just enough to confirm a diagnosis, because there weren't a lot of treatment options. Now we're asking the clinician or the provider to take as much as possible, which is because they have to run a lot of different diagnostic tests on it. That's a complete shift in how healthcare had been practiced up to this point in time. So it's retraining entire professions on how to do something differently. To the pathology lab, and to the pathologist, where historically, they might test for one thing or two things. Now we're asking them to test for 10, 12, or 15 different biomarkers. But so historically, what they would do is they would get their tissue and they would shave it down, the tumor, until they had a slice that they thought was good. And then they would do the test on that and throw parts of the tissue in the trash. That's not really tenable anymore. So they, again, at the pathology lab, needed to, think differently about it, all the way through to how doctors were using the test results, educating patients on the importance of waiting for their test results, and then reimbursement as well along the entire way. Next slide. So based on first the journey, then the barriers, we developed interventions or different types of activities that we could do to help address these barriers along the way. This is a very high level snapshot of what we did and are doing, but it grabs all the important information together. And I do think that this is something that can be used as a tool in many diseases and for other aspects of the disease, but really especially with respect to biomarker testing. Next slide. And so, Helena, I will turn it back to you. I hope that that framework was set up so that people can make use of it. I'm happy to answer questions later.
Thanks so much, Andrea. You could go to the next slide, please, Sylvia. So what we did, as you can see with the example from longevity, we were really struck by this, and we thought that it was really interesting how they approached it and how it was a very practical way, we thought, to be able to map out that patient experience and also to understand what might be the different barriers that might be experienced at different stages of this patient pathway, and also to consider possible solutions. What was quite interesting was that in the course of this journey that we were on, we also came across some other resources that took this approach quite similarly to the longevity approach. And these were all shared to us by the FT3 community. And indeed, if you know of any others that are similar, please let us know. We'd be interested in hearing from you. So in the middle, you can see something that was shared to us from the National Oncology Alliance Rare Cancers Australia. It's a 2020 to 2030 strategic vision. And in here, what they do is they illustrate a patient called Scott, and they show the patient journey of this patient throughout their experience. And they also compare his experience with the experience he could have had he had the ideal access to all the care that should have been available to him. There was also a really interesting paper that was shared to us from the IQVIA Institute called Optimizing Oncology Care Through Biomarker Adoption, Barriers and Solutions. And in this paper, they also outline the patient pathway. And at each point in the patient pathway, they identify what are the more practical access barriers that are experienced. And not only what are the barriers, but also who is experiencing those barriers? What are the different stakeholders who experience these barriers? And the paper goes into lots of interesting detail about what are potential solutions to overcome these barriers. So what we did was we took these learnings and we took these good practices and we said, okay, this was really helpful for us to be able to understand ourselves how to approach this very complicated topic of precision medicine. What could we do to turn this into a model or a framework so that others could also benefit from it and work on it in their own focus areas? So if you could go to the next slide, please, Sylvia. So what we did, we were a little bit inspired by the business model canvas, but what we had in mind was to create a really simple framework that anyone could just draw on the wall or print out and be able to go through the same steps. And we came up with a step-by-step approach. It's basically a presentation format where you just click through basically, and it holds your hand and walks you through that journey. What we did was you will see that it's heavily influenced by the longevity example, where we have different rows for different stakeholders. And the idea is that you would draw out what that pathway might be and the different barriers and solutions that might be experienced. We did try to get some feedback from the FT3 community to see where we could enhance the best practice from longevity still further. And there were a couple of initial feedbacks that we received that were quite interesting. One is that we have been hearing how important it is to consider the patient experience. And what we did was we had this idea to add in a swim lane to be able to illustrate the patient experience in terms of how they might be feeling or what they might do. So for example, they're feeling very anxious at a certain point, or maybe they're not able to sleep, or that they're going to some friends or family for support because they're feeling very anxious. to be able to capture that patient experience. So it's not just about the patient and their symptoms as though they're not a person. Another addition that we consider doing is to add a step. So after the barriers are identified, is to consider maybe what might be the root causes of that barrier. For example, using a fishbone methodology or Ishikawa diagram to be able to really understand what is behind that barrier. And these are just ideas at this point, and part of the objective of the discussion today is to see how we can take this draft approach a step further. I just wanted to underline what Andrea just said a few moments ago. In her example, she explained how there was a lot of multi-stakeholder collaboration that went into that. And we believe that this is also really important in this approach. And in this canvas, we encourage the use of different multi-stakeholders to come together in a workshop kind of format to work on this. Next slide, please. Now I'm just going to walk you through step by step really how this works. So the idea is that you would print out or draw this, this framework on a wall, or it could be on a screen if you're in a remote setting, and to really just to try to map out and to draw out what that patient pathway might be. The next step then would be to identify what might be the barriers at each step of the pathway, just like the longevity example. And then optionally to add in another step, which is to identify what might be the root causes of those barriers. And then finally, to take each barriers one by one and to see what solutions we can think of to address these barriers. And maybe this might be done in the course of several workshops and not just one. You go to the next slide, please. What we also did was we created an example canvas, and this was drawing on the examples that I had mentioned to you before. And also knowing that in precision medicine, we know that there is not one simple pathway that applies to everyone. But we also wanted to pull together some known barriers and known solutions that could inspire others to put their own pathways together. And this is difficult to read here, but we can send that around afterwards and you can look into that in more detail. And again, I wanted to underline that this is just a first approach. What we wanted to do, and the purpose of this workshop today, is to take an example and work together on this to understand a little bit further. We have some questions that we would like to hear from you. How could you imagine employing the canvas in real life? Are there any stakeholder lines that are missing? We had heard, for example, that it might be interesting to consider the caregiver, or maybe it would be good to split the healthcare professional line into different kinds of healthcare professionals. But really like to hear from you on how we can improve this canvas and make it really practical and a usable tool for you. And what we will be doing now is we will be using the example of the cancer of the unknown primary. I'm really delighted to be welcoming Juanita, Tanya, and Caroline here to explain to you a little bit more about CUP and to explain an example they have put together. And then this will follow with a group activity to build on that still further. Over to you, Tanya.
Hello, thank you very much for inviting me today. I'm delighted to have a chance to chat about our work in cancer of unknown primary. My name is Tanya Knott, and I'm the director and founder of the Sarah Jennifer Knott Foundation. I set up this foundation nearly 5 years ago now. My sister died at 31 of cancer of unknown primary. And even with my background as a nurse, I thought when she first got sick that she would have a proper care plan, proper care pathway. But when we realized that they didn't know where the cancer, what type of cancer it was, we started having a very difficult kind of a pathway. And we didn't have all the usual support that you would have had with a different cancer diagnosis. We felt, there's supports for every different type of cancer, but with cancer of unknown primary, there's so little known about it that we felt that we were on our own. And I suppose many people with rare diseases will probably feel that way, that you research it so much that you nearly become the expert yourself. And it's quite scary to think that the patient knows more than the doctor. And I suppose our foundation, when we did find out so much, we realized obviously that there is a lot known about it, and to try and share that information and to make sure people could access the information. Next slide, please. So just to give you a bit of background on what it is, this is kind of very medical explanation, but patients usually present with metastatic disease, and it's kind of hard to find out exactly where the cancer started. For example, if you have a secondary lung cancer, you could find lung cells in the kidneys. But with cancer of unknown primary, when they find the cells are unrecognizable because they're so different to anywhere else in the body that they can't tell where they actually came from. So most people on presentation are very, very sick. I think 57% of patients present in a medical emergency. So by the time they're actually diagnosed, the disease is quite advanced. So they really need quick and careful care plans, and as quick as possible. And I suppose a lot of time is wasted. I think CUP patients can have up to 18 diagnostic tests before they get a diagnosis. So I suppose this is where we're really advocating for personalized medicine, in that if we can get patients earlier in the system, that we might be able to get more of a chance of better treatments for them. A CUP is the 4th most common cause of cancer death worldwide, and it is the 10th most common cancer diagnosis in the Western world, at approximately 200 different types of cancer. So although it's considered unusual, it is quite common, I suppose, in many ways. But next slide, please. Just to show, this is kind of what the feeling is like for the patient, and I'm sure many patients can feel like this. You go to the doctor and they literally are going to subject you to so many different tests, not really let you know what the answer is going to be. They might try drugs that won't necessarily work, terrible side effects, and you might feel worse than you ever did before you saw them. And the patient is so innocent in that they've no kind of choice in the matter, I suppose. So I suppose our organization wants to make sure people know as much as they can about it and consider all the different options. Next slide, please. I think this slide is a really brilliant example of how patient organizations can really share the change to occur. This is a slide of John Simmons. He's the founder of the UK Cup Foundation, Joe's Friends. And he was the first person I went to when my sister got sick. He set up this foundation 15 years ago. And when he started in 2000, he lost his wife to Cup. There was absolutely nothing known about it. So he set up his organization and really started putting pressure, like within the hospitals, within the government, to try and change the course direction for these patients. There was no proper treatments. There's no agreed definition. Caroline's going to talk to you more about that, which is really important. The treatment was ad hoc. Sometimes I might guess the primary and treat accordingly. And there was very little research being done. And what they would try to do is find the primary or find the best closest guess and then give empiric chemotherapy. In 2010, John was part of the NICE guidelines, which all of a sudden sat down the experts and made them really focus on this type of cancer and what could be the best management for it. And if you look at now what's happening in 2020, all of a sudden, it's really starting to take some spotlight in the cancer research world. They are recognizing it more as a disease, the rise in diagnostic expertise, proper pathways, genomic advances, and a lot of research. I think Juanita and I can say we just recently had our World Cup Awareness Week, where we brought researchers from all over the world to talk about the research they're doing, to try and bring them together, that we can have one-stop shop, because even in this time when there's information everywhere, it's still extremely hard to get the information you want. So by having our worldcupawareness.org website, we can put all the research there so people, patients, families, researchers can all kind of access this area and try and find out the most important information. And this is where personalized medicine comes in for us, is that it's a major help for patients with cancer 1 and primary. And I think you can see the inequalities in the different countries. Being a part of the From Testing to Targeted Treatments group means that we can work together with all the different countries, find the best practices and try and bring them into those countries that don't necessarily have them, and learn from best examples. Next slide, please. And I suppose, again, the benefit for genomic profiling for patients with CUP is that a lot of patients will have a unique molecular profile. So rather than giving generic chemotherapy, if the genomic profiling is done at an early stage, you can really try different treatments for the patient. Especially now, it's so many pipeline drugs coming in the future, it won't necessarily matter where the cancer started. It'll all depend on the type of mutations that the cancer harbors. And in the future, it really won't be a question of what type of cancer you have. It'll be what kind of personalized approach do you need. And as we see, 85% of CUP patients can have actionable mutations, but why aren't all CUP patients having the access to these tests? And I suppose that's really what we're trying to help do. So in the future, yes, as I said, the different treatments will really depend on the proper diagnosis test. And by having proper guidelines, having proper advocacy groups, we can try and really make sure that patients can access what they deserve as soon as they can. I'm going to hand you over to Juanita now. Thank you very much.
Yes, thank you so much, Tanya. I think we are on the next slide already. So next slide, please. Yes, so first of all, I will introduce myself. So my name is Ranita Minnaert. As Tanja said, I'm the co-founder of the Dutch CUP patient organization, Missie Tumor Onbekend, which translates to Mission Tumor Unknown. And we actually started in 2020. And what Tanja mentioned, she reached out to John in the UK, so I reached out to Tanja in Ireland. So it's actually quite good to see how relatively small groups of cancer can also really work together on patient advocacy side. So Tanja just briefly introduced what cancer of unknown primary is, and I think it would be great to also have a small video about the journey of an actual CUP patient, so we can see her pathway. The video will start shortly, but it's about Karin, and Karin is the sister of my fellow co-founder in Missie Tumor Onbekend, and she lost her life to CUP in 2012. And she has been one of the key inspirators for us to start this mission. So let's have a look at her journey first before we continue. So we can go to the next slide. So as is clear by Karin's story with CUP, pathways for these patients have been far from ideal. And it's one of our key objectives to change this. And there's also great potential to do so in this coming day and age because of the increasing focus and possibilities around precision diagnostics and treatments. And of course, by learning from other disease groups and patient advocates, such as in the area of lung cancer. So patients deserve an optimal journey as best as it can be, even though if they're terribly ill and their diagnosis is not complete, that should not be the bottleneck for an optimal journey. And we also believe, especially with CUP, precision diagnostics and precision treatment can play a crucial role. And one of there are many challenges in the pathway, and I guess one of them is that CUP is by definition more of an exclusion diagnosis rather than a disease that is diagnosable immediately. And there are several more barriers to the CUP patient pathway. If we can go to the next slide, I can walk you through some of these. So what are some of these barriers? So on the slide, we have now put 5, and we can always debate about what is the most important barrier, but we decided today to start with the lack of awareness. So the name already mentions it. It's a cancer of the unknown primary, so there's an unknown part. So what is that, and how should we look at it? So in terms of raising awareness, it's quite challenging. That applies to the medical professional levels. For example, in Karin's video, we saw there were no case managers in the Netherlands specifically for this disease. But definitely, even at oncologist and pathologist levels, not everyone is aware of CAP, and people always often think this must be such a rare, unique case. They don't see that these patients are in group actually quite large, and that is partly because patients with CAP can have very different symptoms or very different physical complaints, as the metastatic sites can be found basically in any body part. So someone with a metastatic site in the liver and another one with a lung, they can still be part of the same CAP group, but often medical professionals and society will not look at them as being as part from one group. And there's also a lot of unawareness at patient and family level. Patients that we speak to or reach out to us, they always think that they are the only one, and they never heard of CAP. So when they try to explain their disease to other people, to family members, people always say, oh, I never knew CAP existed, and what is CAP, and how can you have cancer when there's no primary site that we can relate it to? So there's a lot of need to be done on the awareness level. Another key barrier is also something that Tanya also mentioned already, but there's a lack of uniform definition. So in one country, a CAP case can actually be diagnosed by performing a certain set of diagnostic tests, while in another region it can mean something totally different. So that's also why it's quite challenging to, as a doctor in a certain hospital, to determine whether you have a CAP case. Are you going to do another round of scans, or are you going to perform another biopsy, or would you stop at some point and say this is a CAP case? And diagnosis is also very challenging because it requires a multidisciplinary team of dedicated healthcare professionalists. And of course, one of the key barriers that, of course, many you already know about is the limitations around diagnostic testing. Tanya mentioned that CAP patients often have many more tests than other cancer patients, but there are limitations to that as well because of for example, the availability of tests. And that means that, for example, at a certain hospital level, certain tests cannot be done, especially the very advanced tests, for example, whole genome sequencing or next generation sequencing is not something that is standard available in every hospital across the world. So as a patient, in a way, you also need to be kind of lucky to be at a location in the hospital where certain tests can be done. And then, of course, we have the suitability of tests for patients, because, of course, you need a measurable metastatic lesion to do a biopsy on. And of course, another challenge is the reimbursement of tests, and that is also very different across geographies. And then, of course, where do you put all these tests in the CAP patient pathway? As of course, which is the key, one of the key challenges is the lack of time. So even if you would say have all the time in the world and you could do all these tests, which test goes where, what is optimal for the patient, and not necessarily what is optimal for the hospital, what does the patient need and what is the preference of the patients, and can certain tests make other tests obsolete? But I guess the two of the key barriers from a patient's perspective are really the lack of time. So the patients pass away very quickly. In the Netherlands, over 50% of patients pass away within 2 months after their first hospital visit. So how much time do you really have? And can you, for example, also say, let's not do all the testing, but try to, support the patient. And, if we know the patient is not going to make it, where do you stop testing? And where do you start providing support? Also, of course, the aggravated emotional impact. Of course, every cancer diagnosis or any rare disease or challenging disease diagnosis is hard, but it's probably more challenging to grasp what is happening to you if you hear that you have cancer, but you cannot locate the primary site, and basically they don't know what to do. And the fact is that they keep on searching for that disease. So try to grasp with that, try to deal with that is very emotionally challenging. Later on today, we would like to hear from you also your perspectives on certain challenges or barriers. And before we try to fill in a recent CAP patient pathway using the longevity example and taking in account the new opportunities of precision diagnostics and medicine, I would really like to now introduce you, Caroline Louf. Caroline is a postdoc researcher with a focus on CAP since 2015, and her work will hopefully soon take away our second barrier, the lack of a uniform definition. Caroline, over to you.
Thank you, Anita. Dear participants, I'm Caroline Loef, and I'm working at Comprehensive Cancer Center in the Netherlands as a CUP scientist and an advisor since 2008. I'm also one of the co-founders of CUP-NL, standing for Cancer of Unknown Primary Expert Platform in the Netherlands. And for today, I will share some diagnostic insights with you regarding CUP. Next slide, please. The diagnosis CUP in the Netherlands is considered as having a metastasis without the source being detected during patient's life. And therefore, the CUP patient population is a heterogeneous group of patients with got the diagnosis by exclusion of other types of cancer, according to the diagnostic recommendations of the national guidelines. Next slide, please. Since the diagnostic workup is different between countries, it is difficult to compare CUP incidence and survival rates. Furthermore, it is hard to understand why patients are treated the way they were and or were not treated at all. Most of all, we miss out on the possibility to learn from each other and to improve CUP healthcare worldwide. Next slide, please. So what to do? We should at least reach out. We should at least reach some consensus regarding the diagnostic techniques used before the diagnosis CUP is given to a patient. Next slide, please. However, reaching consensus is easier said than done. For example, these tables, they come from a publication in which 5 CUP guidelines worldwide were compared in 2015. In the upper part of the table, the initial diagnostic tools are displayed, and on the left part of the table, the guidelines. The plus symbol in the table indicates that the diagnostic tool was recommended by the guideline. And when the cell was left empty, the guideline did not mention the diagnostic tool, or it was not recommended. And what we can conclude from just by looking to these tables without going into further details is that the advised diagnostics by guidelines are quite different worldwide. And this was for me the starting point to find out if we could reach consensus on at least some diagnostic techniques. Next slide, please. And therefore we reached out to several CUP experts worldwide, and 34 experts from 15 countries joined me in my search. Next slide, please. And so far we have reached consensus on the C in CUP, which is standing now for cancer and not for carcinoma, which was always a discussion. We also reached consensus on that the diagnosis CUP should be a layered one, depending on the diagnostic tools used. And a consensus was reached on a set of minimal diagnostic tools resembling the first CUP category of the diagnostic layers. Discussion is still going on regarding supplementary and advanced diagnostics. Next slide, please. The article on the results of this project will be submitted in December this year, and I think this is a really nice example on how we can move forward worldwide to eventually prove CUP research and consequently CUP healthcare. Thank you for your attention, and back to Arnita. Thank you.
Thank you, Caroline. This is actually really great work, and this will definitely help us across the world when there is more uniform consensus on what is CUP and what type of tests need to be included. So now I would like to briefly walk you through a recent example of the CUP patient pathway. Recently, a patient in the Netherlands approached us, and she asked us for support. And she also wanted to share her story with CUP because she realized CUP is not so well known. So if she could help us by sharing her story, that was what she wanted to do. So we decided to really map out her patient journey, and we took the example and followed the example that was briefly explained by Andrea, the example of longevity. So the patient's her journey started in October 2020, when she actually started to feel ill. And of course, as many people have, you start to feel ill, but you don't really put much attention to it. Maybe in a week or two, it's gone. So much more time actually goes over that. So by the time that she really felt a gland in her groin, and she started to actually, I think, get more worried. So she made an appointment with a GP, and the GP said, "Oh, this might be an inflammation. Maybe you go back home and let's come back in a month's time and see if it goes away." That's actually quite common here in the Netherlands, that the GP sends you home, and he or she makes you sure that nothing is wrong and you should come back if it gets worse. So her symptoms actually returned, so she decided to reach out to the GP again. So this approximately took about a month, and this happened when she also found out that there was like liquid also in her neck. So she started to feel really worried, and she almost passed out one morning. So that's why she called back to the GP. And then the GP said, indeed, like the gland in the groin is actually much bigger than it was before. Let's refer you to the internal medicine department at a regional hospital, where the doctor felt at the gland, and he set up several blood tests, and again said, let's come back in a month's time and see what we can do. But at that time, the patient's symptoms got worse, her anxiety grew, and she really knew something was wrong, but she had no idea what was happening to her. So she decided on the morning that she actually almost fainted. She called back to her GP. The GP said, let's go back to the hospital, where she went. And then the hospital also said, okay, let's do a series of imaging and blood tests. And within actually a day, they already found out that actually the spots in her lymph nodes were actually cancer. So what they told the patient is, this looks like a suspected lymph node cancer, which of course is very hard news to hear. But at the same time, she was told lymph node cancer can actually be treated relatively well. And the patient in this story is about 46 years old, so she's not that old yet. So the doctors were actually trying to reassure her that she would be fine. But at the same time, the patient started to feel more worried because she knew it was serious, and she was worried what would happen. So the hospital, the regional hospital, decided, let's do a tissue biopsy the next day to figure out what type of lymph node cancer this is. So they did standard histologic examinations of the tissue. And actually the test here was actually a part of the reimbursement scheme. So in the Netherlands, standard care, standard diagnostics like that are part of the national health insurance scheme. So as a patient, you don't need to be worried about this. So as you will see, this actually went relatively quick. So she, at the beginning it went slow. The GP sent her home a couple of times. Then things got worse, and she rushed to the hospital. They did some further tests. The next day they did a biopsy. And if we go to the next slide, we can actually see what happened next. So they interpreted the test results, and then they actually knew it was metastatic cancer in the lymph node. So it had spread beyond the primary site, and that's actually where the worry really came in. So this was actually around January. It says here March, but this was around January 21 that they knew it was to have been metastatic cancer, but they didn't know where it started from. So to the patients, they mentioned something like, we cannot find your primary tumor, cancer unknown primary, or the Dutch equivalent for that. So the patient was really worried, and she could not understand that this was happening to her. She had never heard of this, and she also started to Google. And then by that time, the first CUP clinic in Amsterdam had recently opened. So she actually told her doctor, given you don't know what CUP is, you have never seen it before, me neither, I want to go to the other hospital. So she actually arranged her referral herself, which was, I think, a very good thing for her to do, because if she would have stayed in the regional hospital, she probably wouldn't have been diagnosed by now, and maybe even worse. So she went over to the CUP clinic in Amsterdam, where they actually started a quite long trajectory of all kinds of tests. So she did blood tests, imaging tests, they did all kinds of internal scans, and several suspected primary cancer sites were discussed with her, as you will see here on the slide. Uterus, intestine, stomach, bladder, anus, they were all checked. And every step it took approximately 2 weeks between the different diagnoses. So that made her really exhausted by the large number of tests, and also nothing conclusive came out of the test. And that's also what I experienced with my fiance, who also had CUP, that every time you put your hopes up and you're thinking, okay, now I should get a result, let's go through this test. But then every time when the answer is negative, you become more and more worried, because at some point you think, am I ever going to get a diagnosis? And is somebody going to help me? Because you have metastatic spots in your body. If no one is going to treat them, that won't end well. So by March, nothing really conclusive came out of it. So that's why when the hospital said, let's do something different. So they ordered the whole genome sequencing test plus the Kappa algorithm, which is a algorithm that the more whole genome sequencing is done on CUP patients, respective CUP patients, the better the computer is able to determine where the primary tumor must have started. And by March, actually, this wasn't reimbursed in the Netherlands yet, but the hospital in Amsterdam, where they were offering this to her, they decided in the early 2019, let's start testing whole genome sequencing on all our patients with metastatic sites. So she was actually lucky that she was in that hospital, where the hospital actually put her in that trial and said, yes, we're going to offer this to you. So the test was then done by her as part of a trial. But as you can see on the lower part of the slide, whole genome sequencing actually became fully reimbursed as of 24 April 2021. And from that moment on, every patient in the Netherlands with a suspected CUP can actually get access to whole genome sequencing. Nonetheless, as I said before, in order to get whole genome sequencing, you need to be in a specialized hospital. So in the Netherlands, that means you need to be in a hospital with a molecular tumor board, which are at the moment 8 hospitals, which should be enough if you think about how small the Netherlands is. But many patients are in regional centers, and like the story of this patient, she had to actually arrange her own referral. But then let's go back to her story. So they started to interpret the results, and they actually said to her, there's 90% certainty that it must have been cervical cancer. So they actually rechecked her cervix to figure out, can we now see it? If the algorithm and the analysis tells us it must be cervical cancer, but can we now see it? And so they didn't, but then in the end they said, like, we should treat you as if you are a cervical cancer patient with metastatic sites. So they gave her a chemotherapy plus a targeted therapy that is also fully covered and reimbursed in the insurance scheme, but only for patients with cervical cancer. So if she hadn't done the whole genome sequencing and she didn't get that result back, then if the hospital decided to treat her for this, then it would not have been reimbursed. So that's why hospitals would not do that. And actually the patient at this point felt really lucky, because she was finally getting a diagnosis, and she felt like, I need this treatment now, because the longer that we wait, my symptoms will only get worse. And fast track to where we are now. So August 2021, so not exactly now, but a month ago. So she finished her 6 courses of chemo and the targeted therapy, and the cancer in her body is gone for now, which is actually really good news. And her oncologist also mentioned to her, like, that they are keen to figure out why she's responding so greatly to this treatment, because the majority of patients with metastatic sites and cervical cancer, they don't respond as quickly and as good as she does. So there's also interesting parts to research, maybe why is she responding better if they can't even confirm she has cervical cancer. But she knows it's incurable, of course, because CUP by definition is incurable because it's a metastatic disease. And she joins us in the mission to sort of raise awareness for CUP patients and help other patients. And from this patient pathway, actually what we are trying to do is we already compared it to the pathway, for example, of Karen, and as you can see, things in terms of accessibility and availability of certain tests have definitely changed, but still, if you think about it, she started having complaints in October 2020, and only by April 2021, she got her diagnosis. That's about 6 months. It's still way too long. So at the moment, we're debating with the national oncologists and national pathologist organizations that the CUP patient pathway in the Netherlands should actually be, the diagnostic part should actually be finished in 6 weeks. And the ultimate objective is to do that in 4 weeks. So that would mean that patients that they start in their primary healthcare centers or in small hospitals, where a standard the set of diagnostics, likely the diagnostic test that Caroline mentioned, that should be, the uniform definition should be performed. Then the patients should be transferred ASAP to the specialized hospitals where there's a molecular tumor boards. They would complete molecular testing. And of course, it mentioned here in this example, whole genome sequencing, but in the end, that is not necessarily in the pathway. In pathway, it will mention different types of molecular testing, and depending on the patient and the availability, the complaints and how the patient is feeling, certain tests will be selected, but likely for CUP, whole genome sequencing is the choice because it's really helpful, particularly if you can also not only find the targetable mutations, but you can also actually try to figure out where the primary tumor has started. And so this was just really like an example of how we filled it in, and we are actually keen to hear your thoughts on other access barriers and other thoughts on the canvas. So over to you, Maxi.
Thank you so much, Juanita. Because we're good for time, I just wanted to pause here quickly and just invite you to ask any questions that you may have for Juanita, Tanya, Carolyn, or Andrea, considering there was a lot of content that we just covered. So to just give you a minute to perhaps, if you have a question, to enter it in the Q&A, and then we'll pass it on directly.
And perhaps while we're waiting for you to collect your thoughts, Juanita, I was wondering if you could share your experiences in using the Canvas approach inspired by the longevity approach that Andrea shared. How was your experience using it? How could you imagine using that in the future as an advocate in precision medicine?
Yeah, I think it has been really helpful. And of course, there's no need to reinvent the wheel. So we were actually really excited to see the examples that have been said to us by the lung cancer organization. And as Andrea also mentioned, in lung cancer, precision diagnostics and precision treatment have already come quite far. So for CUP, it was very logical to look at that example. And for us, we're now also mapping a couple of other patients as well. And it's good to also really map how does the patient feel in all this, because even in our ongoing discussions with the national organizations of oncologists and pathologists, there's always a lot of focus on, okay, what is important for the hospital and how efficient can we make things? And they tend to they care about the patient, but they sometimes really forget how things are for the patient. So that's why we're also putting a lot of emphasis on that. And I think in the video of Karen, we really showed there needs to be case management for CUP patient, because as a CUP patient, you have so much more tests and so much more moving parts. You need somebody who sort of manages that for you. And for us, it will be really helpful to continue to map the different routes, to also show to many of the medical specialists, CUP patient A is not the same as CUP patient B, and there are many different type of journeys, but we're trying to figure out what are the mutual parts, things that we can focus on in our advocacy to say this needs to be improved and this is the reason why. So it has really been helpful to do that exercise.
Thanks, Juanita, for sharing your thoughts.
Lola asked in the chat, 1 second, I've lost her. How do you as a CUP patient group see the purpose and use of such a patient journey map?
I think, especially for us advocates, as patient advocates, you're constantly trying to prove the patient's point and what they have to put up with. So I think maps like this can really help you explain to doctors, especially to government bodies, government agencies, reimbursement payers, that these are the challenges and how easily they can be overcome. And you can have real life examples of how straightforward one patient's pathway could be versus somebody who experiences all these barricades and blocks. And I suppose when you're dealt with opposition, you can kind of argue that, well, in this country they're doing this, and in this country they're doing that. Why aren't we doing it here? So I just think the real life example of it really helps in that way. And I think the great thing about the canvas is it can be used for whichever type of illness or problem. It's just a canvas is exactly that, so it can be used for any patient group.
Great, thank you so much. We will now move on to the group activity. So this is the part where we would like your input. So the group activity, we'll be using an online tool called Group Map. I'll explain how to use it in just a second. but to basically explain to you what we're looking for. So now that you've heard all these talks and the idea behind the canvas, we would like to know from you what other potential access barriers that you may know or could imagine being relevant to CUP or in precision medicine in general. So it doesn't have to necessarily be something that you know about the CUP pathway. It could be a different barrier. And we really want you to be as specific as you can, because we want to see what are the less common barriers that we might not have thought of or might not have encountered. And then as people input these barriers, if you have encountered or experienced that barrier as a patient or in your area of work, we would ask you to like the barrier so that we can see if this barrier has been encountered by many or if it's a less common barrier. And we also invite you to comment on that barrier. So in what situation you might have experienced or encountered it. And then you'll see a second column where we are collecting best practices or case studies that you may have come across that address these access barriers, or any ideas that you might have that could possibly address a barrier. And these best practice or case studies, you are also welcome to like and comment on. So I'm now going to post the link in the chat so that you can go to the group map. So you will be asked to enter your email address, but you don't have to register. And there will be one warm-up question first, which is just asking you what stakeholder group you belong to. So we're going to collect everyone here in the first instance before we move on. I see plenty of joining. We'll give everyone 2 minutes to indicate their stakeholder group. So the numbers are going up. Does anyone have any difficulties joining? No.
So just as a reminder, you just need to click on that link that was shared in the chat and it should bring you to this page. We will give you another minute to connect, as we know it might take you a little while to do that. And once you answer this warm-up question, we'll get to the main screen and we can remind you what we need to do.
Okay, so the majority of you are on the map. I hope that everyone has indicated their stakeholder group, and now we come to the next section. So basically, so you can see the two columns. On the left, we would like to talk about the barriers. On the right, we would like to talk about the best practices and case studies. So in order to add, you just click on the plus and you just type in and click, and then it will be added. You can see the like thumb next to on the right of each barrier or best practice. And if you want to comment, you need to click on the barrier, and then you can add a comment in the bottom.
Perhaps another point to add, we have been discussing the cancer of the unknown primary today as an example, but we don't require you to have any knowledge of CUP before today's session to participate in this activity. We wanted you to consider, from your experience and area of work, what are some barriers that might be applicable to the CUP case. What we wanted to do was to ask you to especially consider perhaps less common barriers. There's some barriers that keep coming up over and over again in the discussions in precision medicine, such as reimbursement and access, but perhaps there are other barriers that might be less well known, and we would be really happy to hear your insights here.
Also, you will see the way that the group map is structuring itself. So the more likes, basically, so the more this barrier has been encountered, it will move up. So we at the end will have basically a prioritized list of the most common barriers, going down to the lesser common barriers.
As we continue, it might be interesting for Tanya and Juanita to hear from you on the barriers that are being shared. If you have experience with the patients that you work with, experiencing these kinds of barriers, please feel free to share your insights there.
I think we've seen them all, really. I'm sure Juanita would agree. I think the first thing is the awareness not to even have the discussion in the first place. You know, and I know in Ireland, in some cancers where the drugs are reimbursed, they can access precision testing. But if it isn't, it's really up to the patient to sometimes ask for it to be done. And that can bring all kinds of issues as well with it. So I think awareness is huge. And then again, it's the reimbursement issues. I know there's definitely been improvements of late with reimbursement issues, so that's really great. And hopefully that can really make a difference. But I think, as Caroline said, if we can have the guidelines, proper guidelines, then there won't be need to fight so hard to get access to the tests if the guidelines are there and they're being used for the patient pathways. But and I'm sure these work through all the cancers, I suppose, because when you see the improvements that have been made in lung cancer and breast cancer especially, it really is incredible, and it's trying to get other cancers the similar kind of access.
Yeah, and I think also it's good we've seen all the challenges here in the Netherlands, and some of them we still see, but by trying to focus on getting the reimbursements in, we've seen actually so many of other barriers being reduced because of the fact that there is reimbursements, new CUP clinics are opened, there's a lot of interest from hospitals, researchers, and also even commercial companies that are looking into CUP because they feel like, oh, something is reimbursed for CUP, let's try to see if we can do something there as well. So there's also much more awareness in the Netherlands nowadays. So I feel that certain barriers and certain opportunities, you know, they have like an effect whereby you solve one, you can actually solve much more. And I feel often the cost is of course very challenging, and sometimes it's impossible to do something about it. But I feel from what we've done in the Netherlands in the past year, we really focused on getting that reimbursement done, and to get all the stakeholders in the country on board. And here in the Netherlands, we love to always agree with each other and debate forever. So it took ages, but finally there is some change, and then you have this sort of it trickles down to other barriers. So that's actually the good news.
And just to underline again that the barriers or the best practices you add do not need to come from your experience in CUP. It can come from your area of work, whether it be lung cancer or breast cancer, or indeed your experience as a patient. So please feel free to add in any of the barriers or good practices that you might have experience in. And this will provide some really helpful input for the CUP team to be able to take this away and explore further and complete their pathway. It's interesting to see that in the best practices and case studies column that the molecular tumor boards are getting a lot of likes. Indeed, this is a subject that I know from my experience comes up a lot in the FT3 discussions. Again, in the CUP World Awareness Week that just happened a couple of weeks ago, there was a very interesting discussion there about the importance of having a multidisciplinary team of dedicated healthcare professionals with different areas of expertise to be able to support there. And if you have any specific experience running them or knowing how best to work with molecular tumor boards, please add that into your comments. We'd be really happy to hear from you.
Another thing that I find very interesting is that health literacy has been, I don't want to say the word voted, that's wrong, is the highest in the barrier section. And I think that's, I think it's very known, but I feel like it's not the first barrier that we always think about in precision medicine. So I find that very interesting that is such a common barrier in this group map.
And I think it's probably one of the most important things, because I think if you're going to start this discussion about genomic profiling with your doctor, you need to have so much facts behind you, because otherwise you can get a simple no. And then you're like, all right, then, what do I say next? So I think you need the background of information to really kind of question why and why not, and what about this opportunity, what about that opportunity. So I think forearmed is, the most important thing, to have the information when you're starting the discussion. And it is very complicated, and it's hard to know exactly, what to ask, but I think that's where we can really help, by having the kind of information available to start the conversation.
Absolutely, yeah.
I see some people are adding some very specific personal examples of what they have done in their own experience. Please continue to add these, because this is where, when we were preparing with the CUP team, they were particularly interested in knowing about specific case studies that had been done in other areas that they could build from. So please feel free to share those, and not just general areas of best practice.
I also like that in the best practices, the whole cross-border part is also being recognized. And I think that is also really key to what we're doing in CUP. And I think there are many more diseases which, can be on a national level or regional level, be very small, but, you can always make a bigger group and, advocate for a bigger impact if you, move across borders. And I think with CUP, that has been also really helpful. And I think with other cancers there, you can easily do the same, or other diseases.
So perhaps we'll give another couple of minutes for everyone to finish adding in their ideas. And I think what we can do is also to keep this open for a couple of days so that you can take the time after the session and to really think about your experience and put them in, and perhaps invite colleagues to do that as well. So I just want to check if there are any other comments from the panelists, any reactions on the suggestions that have been made from this group of people today, or anything that is that you find surprising before we move on?
Yeah, there was just a question there from Roxandra, and it was just how different is the patient pathway for someone with a more common type of cancer, for example, breast. And I think this is the problem for CUP patients, is that because there's no kind of centralized approach and many places don't have CUP specialists, there is no right or wrong kind of pathway, and it's very much dependent on where you're attending, like Juanita mentioned, the regional or the main centers, how different your care can be. And I think with breast and lung cancer now, there's so much known about it that you most likely will get a very similar treatment, you know, in most countries, because there's adequate guidelines, there's access to different testing, there's treatments available. Whereas I think the problem with CUP is we're so far behind, and many other, I suppose, not so well-known cancers, we're behind because I suppose we've been left behind. And that's why things like getting genomic profiling in the pathway will make that change. It'll be the quickest way for it to happen. And I suppose for patient organizations and patients to be advocating for it, because nobody else will, if you know what I mean, unless the pressure's put on. And I think building these kind of examples can only show what they're missing out on. So I think that's the big issue for CUP. We are way behind in many ways, and it's trying to get proper access to treatments and testing.
Yeah, I think actually, Tanya, I think in the lung cancer space, the journey is quite similar up until the point of diagnosis, because many people are misdiagnosed. It's generally an asymptomatic disease until it's quite advanced. So it's often misconstrued for bronchitis or pneumonia or allergies or some other pulmonary distress, and people are given years of antibiotics before they even think of lung cancer as an option, particularly for people who don't smoke or have stopped smoking many years ago. So there's not an there's not a diagnostic test or a detection test, except in the very heavy smoking population, which is why I think many patients actually follow a very similar journey in terms of getting diagnosed initially. The difference is it's once they are tested, it's not a rule out disease. You can test very specifically for it. It's just getting them to that point in time. It's similar.
Great points. Thank you for sharing.
Okay, thank you so much, everyone. So as Helena said, the group map will still stay open for a while, so you can return back after the call. And now I'll hand over back to Helena for the concluding remarks.
Thanks, Maxi. And if Sylvia, if you can move to the next screen, please. I wanted to share just some conclusions to wrap up the very good discussion today. So some of the things we discussed how access challenges in precision medicine are very complex and interconnected, and the importance of taking a whole health system approach. Also, the importance of starting with the patient experience. And I think this was really interesting in the comments that I was seeing coming through the chat and the discussion we were just having now, how important everyone feels it is to consider how the patient is really experiencing, how they are feeling, what they are doing. We talked about the access barrier cause effect canvas, which is still in draft format, but the idea is that this should be a framework. It's a model that we can all use to apply this thinking inspired by good practices to our own areas of work. What we wanted to underline, myself and the panelists, was that this is more a framework or a thought process that is designed to be adapted to your specific needs. It's really important, we think, to consider what are the real barriers or operational access barriers beyond education awareness, and also taking into account all perspectives, or rather, what are the different barriers that might be experienced by different stakeholders. And I think just in reacting to the comments and the discussion we just had, it was quite interesting to hear from the CUP team the potential to use this, the framework, the Canvas approach, to compare and contrast the experience of patients and to see where they diverge or where they converge. And again, this is a draft approach, so we really appreciate your feedback. You're welcome to share your reactions here in the chat. We will also share our contact details, so you can email us. And indeed, if you are interested in participating further, you can contact us, and we would be really happy to have your participation. In the FT3 community, we are also looking for to hear from your experiences and stories, if you are a patient or work with patients. And if you can move to the next slide, please, Sylvia. I also wanted to invite you to join the FT3 community of practice. Again, it's really important for us in our way of working that we can hear from you and collaborate with you, not only to develop our tools, but also to start to test and share the outputs that we are developing. Everything that we do is co-created, and we really rely on the expertise of these diverse stakeholders to be able to move forward. So we have different work areas, and we have sub-working groups as well. You can see some of the different focus areas we have right now and where we are working in smaller production groups. What you can do in joining the FT3 community of practice is to participate in creating these practical tools and resources for champions in precision medicine. You can also participate in giving feedback and testing our outputs. And indeed, if you are really keen on precision medicine, or if you know if there is a place that is ready to accelerate precision medicine, or someone who's ready to act as a champion and is willing to take the tools as we develop them and to try to apply them, please let us know. We'd be really interested in working with you. And we will share our contact details in the chat, so you can contact us. There is also the website. We will also follow up with a summary of the session and the recording, so that you can explore in more detail and give us your reactions. And finally, I wanted to mention that there will be a survey that is sent out after the session. The purpose of the survey won't just be to get your reactions on the session itself, but we'll also include some questions specifically about the Canvas. So to get some feedback from you on what aspects could be improved, maybe to consider what other stakeholder types we might want to include. I already saw some really interesting feedback that came in through the chat, but please take that survey so that we can hear from you. And there will also be an opportunity for you to write down your name and contact details in case you would like to be involved. And indeed, the Canvas is one of several tools that are in development by the FT3 team and community. And we really rely on your support to be able to make a difference here. So thank you very much. Really appreciate your attention today.